Hi there, Dr. Terry Shaneyfelt for UAB Department of Medicine. In this video, I'm going to discuss the perioperative management of patients with diabetes who are taking insulin, both type 1 and type 2 diabetes. Now, there's not a lot of evidence on the optimal perioperative management of diabetes, so a lot of information when you look at guidelines or look at suggestions or just that suggestions based on opinion, so keep that in mind. And the goals of glycemic control are fourfold. We want to try to avoid hypoglycemia. We want to prevent ketoacidosis in the hyperosmolar states. We want to maintain fluid and electrolyte balance and avoid marked hyperglycemia. Now, optimal perioperative glycemic targets are somewhat unclear, and they really are very opinion-based. So the American Diabetes Association bases these recommendations on extrapolating data on hospitalized patients, and they recommend fasting blood glucoses should be less than 140 and a random blood glucose all less than 180. The Canadian Diabetes Association recommends that perioperative glycemic levels should be maintained between 90 and 180 milligrams per deciliter, and this is entirely based on expert consensus. So there's no real consensus on the optimal management strategy to maintain these target glucose levels. Different endocrinologists or physicians that you talk to will have different ways of dosing insulin, and so I tried to put these together and come up with what I think is a reasonable consensus on how to manage insulin in the perioperative period. An important thing is try to get your surgeons to schedule their surgery as early as possible in the day to minimize the time patients are without food and to have minimal disruption in their insulin regimen. So what about patients who need short procedures, and this is procedures less than 2 hours? Well, if these are a very minor early morning procedure in which you only anticipate breakfast will be delayed, patients can continue their long-acting or insulin pump at their usual basal rates. But what you should do is delay their morning short or rapid acting insulin until postoperatively and right before they begin eating again. So if patients need a late morning or early afternoon short procedure, one that will definitely cause them to miss breakfast and either miss lunch or at least have lunch delayed, you want to omit their morning short or rapid acting insulin. Now, if they take an AM only mixed insulin, that's either intermediate insulin mixed with a rapid acting or a long acting insulin mixed with rapid acting, you want to give 1/2 to 2/3 of the usual total morning dose and only give it as NPH or long acting insulin. If patients take twice or 3 times a day mixed insulin, you want to take 1/3 to 1/2 of their usual total morning dose and give it as NPH or long acting. Now, what I like to do is just use the half. I can remember give half of the morning dose, and I usually give it as NPH, but some people will give it as long acting like glargine. So if patients are on an insulin pump, I've seen 2 different things reported. One, you could continue their basal infusion rate because they do need some basal insulin. I've seen other recommendations to convert their dose over to that of a long-acting insulin and give that subcutaneously. There's no right or wrong way. There's no comparison studies that I'm aware of. Patients will need some glucose though, so you should give D5W or D5 half normal saline at 75 to 125 cc's an hour. This should be enough to give them enough glucose. You want to check their blood sugars hourly and then give correction short-acting insulin if they're not at the glycemic targets that you've set for them. And you can use your standard sliding scale that you use for other hospitalized patients. Well, what about long and complex procedures? Here, IV insulin is going to be preferred over subcutaneous insulin for 2 reasons. One, IV insulin has a short half-life of only 5 to 10 minutes, so you can titrate it much more easily. And also, because it's being given IV, you have much more predictable glucose control than you do with a sub-Q route, because cutaneous absorption could be affected by the surgical procedure, by hypotension, etc. Importantly, you need to begin the insulin infusion prior to surgery. You don't want to wait till the patient's in the operating room or right in the pre-anesthesia care unit to start their insulin. You want to try to begin in an hour or 2 or more before surgery so that you can achieve a steady state of glycemic control. And you also need to give these patients glucose, and there's really 2 ways to do that. You can use a glucose insulin potassium infusion, or you can do separate insulin and glucose IV solutions. Now, I prefer the second one, the separate insulin and glucose solutions, mainly because the GIK infusion tends to be a premixed bag that has often 15 units of insulin in it and 500 cc's of dextrose, and that's to me a little bit more difficult to titrate than if I have a insulin drip mix in the concentration of really maybe 1 unit per cc, so that it's easier for me to titrate up by the units that I want, and I know they're getting exactly the amount of units of insulin that I'd like them to get. So how do you decide on your initial infusion, insulin infusion rate? Well, you take the patient's blood glucose, you should do one right before you start this, and divide that by 100. So if the patient's blood glucose is 300, I'm going to start at 3 units per hour of IV insulin. You need to check their blood glucose levels. I prefer every hour, but it's written as every 1 to 2 hours. And then you can titrate your insulin infusion based on glucose, and this is a suggested sort of sliding scale, if you will, for IV insulin. Now, importantly, at the bottom of this, if a patient is a type 1 diabetic, even if their blood sugars are getting low, you never want to stop their insulin. They need baseline insulin to prevent ketosis. So that's an important point to remember in type 1 diabetics. Give them more glucose, reduce the insulin infusion rate, but don't stop their insulin infusion. So finally, what do I need to do postoperatively now? So once the patient is eating well, I can resume their pre-op insulin regimen. If patients are on an insulin infusion, we need to give their first dose of sub-Q insulin before we stop the IV insulin. And if patients are on intermediate or long-acting insulin, you want to give that sub-Q insulin 2 to 3 hours prior to stopping your IV insulin. If they're on a short or rapid-acting, you need to give it 1 to 2 hours prior to stopping your IV insulin. You need to get it on board because remember, your IV insulin only has a half-life of 5 to 10 minutes, so it's going to wear off pretty quickly, and you need your other insulins on board and doing their thing. If patients are not eating well, you need to continue their IV dextrose to give them a glucose source because the insulin is going to be present. So let's do a knowledge check. So you're asked to see a 67-year-old gentleman with type 2 diabetes, and he's 1 day prior to having coronary artery bypass grafting. He uses 70-30 insulin. He takes 40 units in the morning and 30 units in the evening as an outpatient. His last A1C was fair. It was 7.5%. He had a glucose checked 1 hour ago and is 188 milligrams per deciliter. So what do you recommend for this patient in the surgical time period? There's 5 choices here. I'd like you to pause the video, consider each one of them carefully, and then restart the video to see how I answer. So pause the video now. So what do you think? So I chose D. And let's go through each one of these. So we don't want to continue the usual dose of 70-30 today, which would be reasonable, but I don't want to give just half of the morning dose as NPH because this is a complex procedure and the patient needs IV insulin. Again, sort of a similar for question or answer B. I don't want to continue their usual home dose. Number 1, this would be sub-Q, and I need IV insulin. But also, it's going to be very difficult for me to try to titrate 70-30 insulin. Beginning an insulin and glucose infusion is the right way to do it. 2 units per hour is the reasonable start range because the blood glucose is around 200, but I don't really want to begin it as in C on the day prior to surgery. It's probably too far ahead of time. So D makes more sense. I begin it early in the morning of surgery. And then E, I don't again want to give sub-Q insulin because this is a complex procedure and the patient needs IV insulin.